for a while. And recently there was a court case out of Australia that I put into the EMDR News site on various things, and birth trauma was one of the things that we have information on. All right, everybody, this is Dr. Tim Vermillion from EMDR News. Sorry, a couple minutes late. Was finishing up with a consultation. We'll probably actually talk about some of the subjects that we went over in that consultation a little bit today as well. If you haven't been on EMDR News, been putting on a lot of information on there in regards to studies that are happening, not just in EMDR, but across the mental health spectrum. And I do want to keep bringing those studies and the information and news to you as we go forward. So there's often grants up there for various populations and various issues and situations. There's also some information on there about different therapies and how they're helping or hindering or not helping at all some different populations and with different evidence-based practices. So if you haven't been following, if you haven't been watching, please take a moment now and go ahead and like, save, share, do all that stuff to make sure that you're getting notified when we're doing these. And we do these every day, right? Generally at 9:30 in the morning, and I plan to continue doing it. So please, tell your friends. Please come visit, ask questions. I'm going to try and get into some of the social areas, some of the groups to get people out there, some questions from them so that we can get some direction in terms of the material that I put out there that isn't just from me, what I find interesting, but what you have questions about in the world. This could be about clinical questions in general, but specifically about EMDR, maybe working with veterans, that kind of thing. Speaking of working with veterans, I have to reach out to Harold Lipke because Harold Lipke and I are in conversation about having a presentation for the special interest group of EMDRIA, for the military and veteran special interest group, on anger. All right. And I do an anger group within the context of my daily work. And I do 2 of them per week. It's an awesome population to work with. And he will be discussing anger in terms of EMDR and also referencing the military population, the veteran population, and how we can deal with anger in those contexts. So I'm looking forward to that conversation with him. And if you are an MGO member, if you're not part of a special interest group, there are a couple out there for various different areas and subjects. Right now, the military one isn't that as active as it could be. It's always been an issue. People do come on there for questions, but head over there and join up if you haven't. Start a conversation, keep the conversation going. Every quarter, I try to have a presentation in there so that people can get something from it. They're usually not CEU providing presentations, but they're interesting and they're have good information. The last one that we had was on um, uh, the we had one on polyvagal theory, and then we had one on sexual trauma. And we had, we had one on transgender. Issues that come along with that, LGBT and transgender. So, feel free and check in to see what's going on with that as well. I'm the chair over there, although I'll probably be stepping away soon because there's a time limit on these things. So hopefully we'll be able to find a good chair to take over and keep the good fight going. So what else can we talk about? Again, go to EMDR News to see some of the new things that we put in there. Let me just go ahead and see if I can't have any of those things specific for you is up there now. EMDR News is kind of where this is, right? So these will live on EMDR News and our live desk. So you can go there and catch up on old ones as well. We also have some podcasts. Usually the podcasts are me reading or a version of the studies and stuff that I discussed, the articles that I put up there. Okay, so they're a little more dry, a little more polished than what I do here on live. But if you're driving, if you want to know about stuff, then it's a good way to do it. I only have a couple up there now, but I'm gonna just make sure that I try to get all of them in a podcast form as well. So some of the things that we have on here today. So PTSD with EMDR and CBT for first responders, right? That was one of those things that came up recently that I discussed. And EMDR and CBT were found to be effective in terms of reducing the PTSD symptoms of the first responders. That's kind of where that one goes, and it was based on 15 studies. The evidence was a little bit uneven, and again, we do want to talk about evidence when we're here because when we bring a research study to you and it says, hey, it works, how generalizable is that though, right? So it's not just does it work, but does it work for who? Does it work when? So the populations and generalizability are huge when we're talking about these things. So how strong is the evidence? I do have some of those things that I add to the bottom of our articles, and I wanted to do that, have some questions available for you to see what you might possibly think about, and I kind of assume what they might be and answer them for you. So for example, what did the review about the EMDR find about EMDR and CBT? Across the 15 studies, EMDR and CBT showed the most consistent pattern of PTSD symptom reduction. The review described a promising evidence signal, but again, not a final ranking of which is better, which treatment is better. um, Let's see. The 7 studies were rated as low risk for bias. So that means like 8 studies, on the other hand, had methodological limitations. And the studies varied in occupation, intervention, sample size, outcome measures, and follow-up. So again, all of these um, contravening variables end up affecting what we can or what we should take from a study. But what do we know? The signal says, hey, EMDR, cognitive behavioral therapy are working, and they continue to work. And that's the part that we do want to carry, right? Is that, hey, it's working. How generalizable it is, can't really sit on that. But at the same time, it is something that we can say that EMDR is helpful and uh, worth doing with our first responders. Um, let's see what else that I have for you today. There we go. Dun, dun, let's see, feasibility studies, field signals, suicide stuff. So we have one from the 21st that talked about the national survey finding higher recent suicidal ideation among veterans, while treatment use differed by whether the VA was the primary healthcare uh, source or not. So people got treated for their suicidal ideation more if the VA was the primary source versus if not, when it was found in primary care. So that was something that's recent. And suicidal behavior, committing suicide, that 22 a day stat is a huge issue, right? It's one of the biggest preventable deaths that harm communities that we have, right? Because when suicide happens, it's a pretty serious issue that we have to kind of look at in terms of how it affects everybody else. And suicide is addictive, not addictive, contagious, right? So there is evidence, psychological profiles have shown that when you do something like you take a suicidal case and put it in a newspaper, all of a sudden you might is the big word there, but you might see more people in that area suicide, right? Kind of gives people permission to suicide, right? Like, oh, this is a taboo. Well, maybe it's not so taboo because people are doing it, right? And they end up following along. This is not trying to say that you should go out and do something like that, but this is just appreciating that issue. I don't see it in here yet, but there's another interesting thing that I want to make sure that I get in here. Um, and that is the online studies that recently happened. I think what I was trying to do is combine two studies, so that's why it's not up here yet. But there's two online studies. One is about people going and looking for community for their post-traumatic stress and various other issues, right? The other piece is children, I don't know, well, teens, I guess, going online and being fed through the algorithm suicidal material, right? People harming themselves, doing self-harm, that kind of thing. And so it was kind of looking at two different angles of how the online experience can affect people in different ways. So I might split them up again, but right now I'm trying to work on something where I can make it a bigger picture about just the online experience in general and how it can go from one end to the next. But when we talk about traumas, big T's and little T traumas, uh, you know, I wasn't born with technology, right? I'm not a native, as they would say. I was on the cusp though, as all this stuff kind of happened when I was in college, but I wasn't born with the technology that we have today. So the natives, the kids that are brought up on it, they probably have different little T's than we can imagine. And when I say little T's, those are the like little traumas, things that affect you in some shape, way, or form that can build up over time, or even serve singly as an issue that is going to change how you view yourself, other people in the world moving forward. So a big T is a car accident, a war, physical assault. There's so many things that we can talk about. The big T, the big trauma. They're the criterion A events, really, that end up on your PTSD assessment, right? Those are the things that say, hey, the DSM would agree that you probably could screen positive for post-traumatic stress if we wanted to do that assessment. The little T's are a little more pervasive, they're a little more nefarious, and they, you know, not getting an A on a report card when all you used to do was get A's and not think about it, and you get a B, and all of a sudden your parents look at you like you got three heads, like all the love got sucked out of the world. And you never want to feel that way again. So you say to yourself in that moment at 6 years old, 7 years old, I'll never get a B again, right? I have to be perfect. Otherwise all the life will get and love will get sucked out of the room. And I never want to feel that way, right? So, we come to these ideas and thoughts based on little T's as well. And these could be also dinner time things where you have people yell at other people during dinner, yell at you during dinner. Those pervasive little T's. Um, so we have a whole nother platform to get our T's from, our little traumas, the things that build up and affect how we think about ourselves, other people in the world. We had the news. We can get vicarious trauma through the news, but now we have these things that are literally fed to us and fed to our youth, right? Our kids and our teens. The algorithm feeds them information on self-harm, right? And it's not just the algorithm. Sometimes it's other people, right? People that they know that are like, hey, look at this crazy thing that I found. So what does that do? And when are we going to note or put that into our assessment? When do we create a position or a piece of our intake assessment that talks about online experience? And is it worth doing? Interesting subjects, and it could be the opposite way too, right? What resources do you get, right? When we talk about phase two stuff in EMDR, or when we are just talking about the barriers to self-harm or the protective factors, are there any protective factors that we will find online, right? And that goes to the other half of that paper that I was looking at, which again is bringing in the people finding support with like PTSD groups and stuff online. So it's strange when we think about how much the online world has found its way into our psyche, and we need to make it a formal process of making sure that we include it in our assessment at this point. That's my opinion anyway. Um, I'd like to hear your opinion on that. So if you want to, please go ahead and leave a comment. I don't see, let's see, comments. I don't see any comments right now, so that's good. Well, not necessarily good, but it is what it is. Let me put in here. Let's see here. Just say go ahead and comment on whether EMDR, or rather, whether online experiences, both positive and negative, should end up being part of our formal intake. Right? So let's see if I put that out into the world, what will come out, will come back. All right. So right now that's flew out to EMDR News and on Facebook, and it looks like on YouTube, and also the Dr. Vermillion site on YouTube, on Facebook. So it's out there. Let's see if we get anybody to answer. And while we do that, we'll continue kind of moving forward a little bit, right? No changes in terms of the my goodness, the conferences. No changes as far as I know, right? So we have MJS next month. Then we have ISTSS, and then we have EMDR HAP. If you have another concert that you want me to mention here, feel free and let me know. I have a relationship with MGA and I have a relationship with EMDR HAP, both nonprofits, both that I have I volunteer for in different respects. And so that's why I bring that stuff out a lot. It's because I volunteer for them. So let's continue a little bit further. Some other things that I might be adding here or discussing, I guess, is more editorial based, I guess. Not always so in deep with the um, research, right? It's ideas and thoughts on moral injury, on neglect, and whether neglect should be something that is even a part of our formal assessment more than it currently is, right? And that comes from a paper that Andrew Leeds, who's a well-known EMDR person out there in the field, he actually put out that paper, I believe, on neglect and considering where neglect should fit. So, you know, these things are not yet in EMDR News, but these are coming. So the upcoming studies of EMDR News, right? The online piece, neglect, and again, some of these other ideas, they're academic papers and stuff that I want to kind of bring to you in some shape or form so that we can continue those conversations. So today we talked about the suicide piece, which is a huge piece that we want to attend to, right? Right now, it seems like there's more suicidal thoughts among veterans, which is an issue. So let's go ahead and move forward to talking about EMDR, like a conversation that I had with a consultant today, right? Because I have consultants almost or consultation in some almost every day, I guess, with some individuals in different contexts, working in different contexts. So today was somebody that had just finished their second training, so they're still in that training piece, and we wanted to kind of talk about everything that they're working on, right? Because they're still learning. They have like 4 of the consultation sessions that they have to do before they can get their certificate, saying that they're fully trained. And that conversation was started with just kind of learning about all this stuff, and how did I, as myself, how did I use EMDR when I first started? What was that like for me? And I brought up, 40%, I think it's 40%, maybe even more. And I put this out before, but 40% of people that go into any mental health training don't use it or stop using it, right? And EMDR is no different. EMDR has a similar statistic. I don't know the exact statistic, but 40% or so of people that go and work on EMDR end up falling back or taking steps back to things that they're more comfortable with, and that's perfectly understandable, right? If you're working with somebody and you get stuck and you're confused and you don't feel confident, you get that imposter syndrome, or you really just don't know where you are, where you're going with it, then you're more likely to step back to something that you're familiar with, and that's clinically appropriate. If you don't know what to do and you want to get the client to be in the best place that they can be, but you have another skill, another therapy that you might be able to use, you might step back and do some of that, and that's perfectly reasonable given uh, situation. It's ethical work. So on some level, for people that continue with different types of therapy and EMDR, it's like a trial and error thing. They'll use it sometimes, and then they'll stop using it a little bit, and then they'll use it some more, and maybe at some point they'll be like, "Well, I know it works. I hear that it works, and I've had some good experiences, but then I get stuck." So, I'll use it some, and then I'll get stuck and revert back to something else. So again, clinically appropriate. And even I don't do EMDR 24/7, 7 days a week. I have other things that I can provide for clients that come in that don't. Not everybody is going to be that same nail that we're going to hit with that same hammer, right? So people are a little bit different, and sometimes they can benefit from a cognitive behavioral therapy type thing more than they might be able to benefit from EMDR. I still consider myself an EMDR therapist. So even when I'm doing cognitive behavioral therapy, I am looking at that through an AIP lens, as odd as that might seem for some people. Um, so with that context, right, I asked the consultee, I'm like, hey, now how you feel right now? You got like 4 more sessions or so before you're done, before you can say, hey, I am EMDR trained. You can take that and you can go plaster it everywhere saying, hey, I am EMDR trained by Andrea. Right. You can go plaster that everywhere. Never ever talk to anybody ever again. No consultations, go to no more trainings on EMDR. Right. You can do that and say, I'm EMDR trained. And people do, right? What often happens with that is that people end up drifting because they don't get the support they need. They end up drifting away and using different things with EMDR. They might advertise, hey, this is EMDR, right? Or I can provide EMDR. They get a little bit of a bait and switch sometimes, because when people come to get research-based EMDR, all of a sudden they're getting some weird Dr. Vermillion version of EMDR, right? That might not be in keeping with the standard protocol, the appropriate ways that we can do EMDR, and flex it based on the actual protocol, right? You get some weird mixture, and people just, it's like EMDR by another name. There's some ethical concerns about that, right? So if somebody comes from EMDR and you're giving them that bait and switch, saying, well, I know better than what was researched, right? And, what if something happens? Do you really have that backup to say, well, I was trained in EMDR, right? And then somebody's like, well, did you do it as you were trained? And you're like, no, I made it better, right? Okay, well, where's the research on that, right? So anecdotally, you can say, well, I've done it with a couple people, and I know I believe that it works, but anecdotally doesn't, get you out of out of trouble a lot of times, right? You got to, if you're going to say that you're doing something, you got to kind of do it, right? um, so there's an ethical piece, right, of making sure that you're sticking with the protocol and doing EMDR within the context of the flexibility that EMDR actually has when you use it. Right? There's a lot of flexibility in it, a lot of different things that you can do when you get stuck, and that's why it's important to consider getting certified, right? And so plugs for certification. Um, when you are certified, you're not telling somebody that I'm trained. Um, I'm doing it my own way, right? You're saying I'm trained, and I also spent time making sure that I'm doing it right and gaining confidence in it through bringing my questions to other people instead of trying to answer them based on stuff that I already do, right? So making up my own answers, in other words. So I go and talk to consultants that are approved to be consultants and move forward and kind of learn how to make sure that I can be flexible within the EMDR system while providing research-based EMDR. Um, so, and they're like, well, that makes a lot of sense, like again, as soon as you're done that 10th consultation for EMDR basic training, you're trained. You can put that plaque up or put it on the back of your back of your name. But again, you're not certified, and so you can say you're trained, but are you competent? You're probably not confident, but are you competent? Right. So that's the other issue. And without that confidence and that competence, you're more likely to drift away, make EMDR something else, or do the bait and switch. Oh, I saw that you do EMDR. Yes, I do EMDR. Let's do some cognitive behavioral therapy. So just to kind of make sure that we are attending to that idea of why we would get certified and what it means. Now, if you decide that, hey, I don't want to get certified, I understand that the drift piece. What I want to do is and you can do this. There are things, people out there. I'm going to go to consultation. I am going to go join a group, right? It's not certified as for certification. I don't care about certification or whatever, right? But I'm going to go and go and get that consultation or join a consultation group because I need that support. Right. So that might be good, especially if you do have an approved consultant within that group that is keeping everybody online with the standard protocol, because groupthink happens, right? And you have that mob mentality, and the group can shift and drift as well. And consultants out there that are not necessarily, approved consultants can drift and shift as well, right? So everybody's got their magic wand out there. Everybody's got their, if they're selling stuff, right? Their marketing gimmick. I'm not going to mention any names out there, but I mentioned this today as well. Like if I am trying to compete with other people that are teaching anything, right? How do I make myself different and marketable? If everybody does the same thing, why would I go to you? So people end up having, their different versions of this phase or that phase or something. EMDRIA allows flexibility within that context, right? They have to meet certain things, but at the same time, they can be a little more flexible on how they teach those things. And I do know at least one name, which I will not mention, out there in training that says, hey, EMDRIA wants you to know this, right? And basically, okay, and now let's talk about this. So that, because EMDRIA makes me do this, this is this, but this is what I believe, right? So we want to avoid that as well. Um, it's another bait and switch thing, right? It's like, I know better than what the research says. And people will be like, hey, there's different types of research, right? Granted, there is different types of research. There's anecdotal evidence. Anecdotal evidence gives us an idea like, hey, this seems to be working. And then we go that step forward. And from anecdotal evidence, we get the case studies, right? And so we say, this works, and I can put it on paper and show what was happening in this specific case, or maybe do it a couple more, right? A couple more case studies. So you can say, well, this seems to be the case for a couple of people that I'm working with. Very ungeneralizable, right? And who knows what the reason is that it is working that way. Like, you could assume it's one thing, but without controlling for variables, we don't know if it's that thing, right? So then we need our RCTs, right? So we do need to work up to an RCT in order to, which is a randomized clinical trial, where we have a larger population that can be representative of the population that we work with, right? A larger population that is representative, right? With that population, we have part of that population receive a treatment, and a part of that population not receive it, right? Or receive a different treatment, so that we can compare what happens when we do this thing that we think that works so well, right? And then we can say, okay, well, it does seem not to work just for my case studies and the people that I work with. It's also working for these other people, right? It's also working for these people that are in a double-blind, randomized control style trial, and it's working, right? And so we can say, okay, well, in this case, it's still testable. We can still take another test, do another RCT, and find out it's not working. But for now, we can say, hey, we have at least one piece of evidence that says, hey, this is working for a representative segment of the population. So we can generalize that and say it's a good chance, above 50%, maybe 60, 70% chance that it'll work for somebody that I'm working with, right? And that's kind of what people look for in government institutions. If it's going to end up in a practice guideline for the VA, for example, it needs to have that backing, right? It needs to have some research behind it that isn't anecdotal, isn't a case study, right? It needs to have some RCTs behind it that say, hey, this is representative. It's not just this, one person or these three people that did case studies and say, hey, this is working for us, right? And then you can also do dismantling studies. Like, what is it about EMDR that works? What is it about brain spotting that works? And this is a question that is still out there. Do we need the eye movements? Is it just eye movements, right? Is it activating both hemispheres of the brain? Is it the working memory theory, right? What's happening biologically, right? So all of these little things we start to dismantle and say, well, maybe it's not the eye movements, maybe it's something else, right? And that's perfectly fine, right? We know it works. Let's look at how it works, and if we can make a better therapy over time based on the research that we're doing, that's a good thing. There's nothing wrong with finding out that something isn't exactly as we had planned it, because then we can use the knowledge to make something better or to improve upon it, right? So do the work, do the research, right? And get that stuff out there. So how we started about this is talking about EMDR and people doing it the Frank Sinatra way, right? I'll do it my way, right? I did it my way, rather. Uh, so the Frank Sinatra way is not the way we want to go in general. We are all good therapists. We do have some flexibility with EMDR, but we do want to make sure that we're still being ethical and doing the EMDR that people are expecting when they come for the research-based, evidence-based treatment. And that goes, we can take a step further and talk about, consultants and what consultants are doing and making sure that consultants are teaching the protocol, right? The same way, same idea, not just the trainers, but make sure that the consultants are doing the thing. They do want to provide information on how they understand it, maybe some tricks of the trade, but all within the context of what is researched and generalizable and known to work. So there's a lot of information that can come from that. I had a consultee yesterday say that they got a client that came in and that had done EMDR before, and so the consultee was doing EMDR phase 1, starting kind of the process, and the consultee goes like, "Well, we didn't do any of this. We did. I walked in and they hand me buzzers." So I'm like, yeah, and I said the same thing. Drift happens. People are trained differently, sometimes inappropriately. They get inappropriate consultation. So when we get our people that have had EMDR before, we don't actually know what they had, and so that's a problem because we need to get back to that generalizability thing, where if I go get EMDR from someone and say, hey, this worked for me, and I go to someone else and they're doing it like this isn't the same EMDR, what are you doing? We got to figure out how to make sure that we're all doing the same thing, using the same language, and when somebody goes to one EMDR therapist, they are getting something very similar to what they're getting from another therapist. And that's not even getting into, adding stuff like EMDR informed this and EMDR informed that. The question, if you're doing IFS informed EMDR or EMDR informed IFS, on which level it is, when you're doing that, are you doing EMDR, right? Because the reason why I'm saying that is the theories are different. Right. So EMDR, generally, the theory that we use in EMDR is more of a structural dissociation type theory of the personality, whereas IFS, my understanding, is more of a everybody's is a multiplicity, right? And it's just not because of trauma, right? Structural dissociation is a trauma-based idea. EMDR kind of is a trauma-based idea mostly. So that's the context. So when you start bringing IFS, like there's some competing theory there, and how do you resolve that competing theory, right? So again, it's an all interesting thing, and research will eventually give us some more information on it. So please do your research. and I try to bring research to you. Um, I don't do as much research myself, but I do try to bring it to you. Um, got a couple of more minutes. It's 10:11 Eastern time. And I'm hoping this conversation was helpful and interesting to you as we kind of move forward, kind of bring us back to EMDR as it's ethically provided versus the Frank Sinatra method. I did it my way. Let's see. Okay. So as we come to a close, I want to remind you all that you can find me in various different places. Uh, and I'm trying to get a little bit on TikTok with some of the pieces of these presentations end up being put on TikTok, right? So I'll be on TikTok, YouTube apparently. I'm maybe even live right now on YouTube. Um, so I'm just, I should be out in different places. So find me where you are, like, subscribe, share, all of that stuff. Let me know if there's some questions that you want me to answer, and I'll do my best to do that. If I'm out there in the world, right? If I'm at that conference and you want to reach out to me or say hello, let me know. If you have something going on, some news in EMDR that you want me to kind of discuss or, whatever that might be, let me know and I'll see what I can do in order to get that stuff out, right? That's what I'm interested in doing. It's what I want to do. I want to get EMDR and the great work that EMDR practitioners do out to the world. Um, right now, as far as trainings, it's a non-for-profits or free trainings or what I'm putting on here. It'd be a different discussion if you're getting paid for it. So, okay. Exciting. All right, cool. So I'm gonna let you all go and give you back some of your time. If there are any issues or questions, feel free and reach out to me. You can get me through EMDR News info at emdrnews.com, and you can like, subscribe, and share. Thank you, everybody, and I'll be looking forward to exploring some more topics tomorrow. Uh, all right. Bye now.